Hello everyone, and welcome back to another Rafael Medina subspecialty virtual morning report. Today, our focus will be on gastroenterology, and for this, we have two amazing guests. As a case discussant, we have Dr. Ryan Flanagan, who is a faculty member at the Brigham and Women's Hospital and instructor in medicine at Harvard Medical School in Boston. He grew up locally in the Boston area, attended college and medical school at Tufts University, and completed internal medicine residency at Massachusetts General Hospital. During his GI fellowship at the Brigham, he completed research projects on a variety of topics, including gastrointestinal motility, the GI hospitalist model, and medical education. He has clinical focus on the inpatient GI consult service and is the associate program director for the gastroenterology fellowship program. And as a case presenter, we have Dr. Allyson Richardson, who is a second-year gastroenterology hepatology fellow at Brigham and Women's Hospital. She was born and raised in Michigan, attended University of Michigan for undergrad, Case Western for medical school, and Stanford for residency. She's interested in general gastroenterology, quality improvement, and healthcare operations. She also enjoys running, painting, paddleboarding, and exploring Boston. And before we jump into the case, I would like to ask both of you why you chose gastroenterology as a subspecialty and what you like to do outside of medicine.
Great. Thanks so much for having us. I'm really excited to be part of this and hopefully make it educational for everyone. I chose gastroenterology because I really like procedures and I like sort of seeing what we're treating, being able to diagnose things ourselves, and then be able to even, for instance, with bleeding, like treat it at the time. And it's a nice balance of being able to do procedures, but also have a lot of the clinical reasoning skills that we use so much in medicine. So it's a nice balance in that way. And something I like to do outside of medicine, I would say anything outdoors. I really like hiking. So we find all the local paths and then also paths when we go on vacation to hike, whether it's mountains, valleys, or by the beach. We're pretty much always outside, and we have a little dog that we always try to bring with us as well. So if I'm not at the hospital, I'm usually outdoors walking somewhere.
Amazing. And Dr. Richardson?
Yeah, I think it's very similar. I think I knew in medical school that I really liked internal medicine and I really liked procedures, and it sort of was a perfect marriage of the two, and also maybe not as acute as like the ICU or cardiology, where I had some time to think about how I wanted to approach the patients. And it's proven that I still like it after a year of fellowship. So, and then in terms of what I like to do outside of the hospital, I talked about this a little bit in my bio. So definitely those things. And then more recently, I've been very obsessed with Formula One. And also I just played pickleball for the second time this weekend. So I'm jumping on that bandwagon as well.
So cool. So I think before we start, first of all, thank you so much for being here. We're so excited for the session. And I would then ask Bettina for sharing the screen with us. So Dr. Richardson, whenever you are ready, please, you can start with the first aliquot.
Yes. So let me. Okay, I'm not muted. All right. So we have for our case today a 68-year-old woman who presents with 2 weeks of worsening diarrhea. So she, like many of our patients that we see, has had sort of a long history of this, particularly over the past 2 years. She's had issues with diarrhea, recurrent episodes, and before that had no symptoms. She had several hospitalizations, and through chart review, she was diagnosed with diverticulitis on 2 occasions and C. diff on 2 occasions. She was treated with the respective antibiotics and then usually had improvement in her symptoms between those episodes. And then in terms of our current sort of episode, she thought it was similar to her prior ones. Started having 4 to 6 watery bowel movements, with mucus. She did have also a little bit of hematochezia, but it was mostly the burden with watery bowel movements. And occasionally would definitely wake her up at night. She had urgency associated with them. She had no fevers, no chills, no nausea or vomiting, and had a little bit of periumbilical cramping abdominal pain. She saw one of her outpatient providers, which started her on antibiotics, but unfortunately she was not doing better.
Okay, so we have an amazing first aliquot. So Dr. Flanagan, what comes into your mind seeing this chief complaint of 2 weeks of worsening diarrhea and this whole symptom complex?
Yeah, so that's a great start, I think, with the history. There's a lot of salient points, even with just this small amount of background. So the things that we know about the patient is that she's in her 60s. And so diarrhea in younger patients, definitely we start to think of the differential a little bit differently. And then we see that it's a chronic diarrhea, so really 2 years of diarrhea symptoms. And so there are some infections that can cause more chronic symptoms, but relatively they're a lot more infrequently the cause of chronic diarrhea compared to something like acute diarrhea. We also know that she's diagnosed with diverticulitis twice. Certainly diverticulitis itself usually does not present with diarrhea, but there is an entity of segmental colitis associated with diarrhea, with diverticulitis, which can present with some inflammatory type diarrhea and symptoms. And so I'd keep that in the back of my mind as well. And then with presumably the antibiotic courses for the diverticulitis, she may have had this complication of C. diff, which we think usually of as an acute sort of diarrhea. However, could certainly be the cause of a worsening diarrhea over the past 2 weeks. And so keeping the differential broad, I'd certainly think about things like inflammatory bowel disease, specifically ulcerative colitis. We're not hearing a lot about blood. There was maybe just a tiny bit. And so that doesn't really fit, but in this age group, we always want to think about that because it can have a later onset. Like I said, infection is less likely. And then other things to think about would be like microscopic colitis, which is a much more common cause of diarrhea, chronic diarrhea, especially in elderly patients. And the other important sort of piece of information here is really the quality of the diarrhea and the symptoms. And so the most common cause of diarrhea in the outpatient setting in someone like this would be irritable bowel syndrome. But here we're hearing nocturnal symptoms. We're hearing some, other history of antibiotic use and C. diff and other sort of risk factors for more of an organic cause of diarrhea. And so I wouldn't rule out irritable bowel syndrome entirely, but the nocturnal symptoms certainly makes that a lot less likely compared to something like microscopic colitis and less likely sort of an ulcerative colitis or chronic infection. And then the last thing I'll say is that we didn't hear any history of immunocompromise, and that becomes really important with any case of diarrhea because the types of infections change significantly, and you would have to have a much broader workup. An infection would start to rise in the differential. But since we don't have that history here, I'm not thinking so much about chronic infections, though they're always on the list.
Amazing approach. A question that came into my mind, seeing the C. diff that she had, is there a typical timeline for antibiotics that we have to consider that are associated with C. diff?
Yeah, so usually you'll see C. diff occur within a few weeks of antibiotic use, really. It's on the weeks to maybe up to a couple months. But usually it's relatively quick because the theory is that you're sort of treating a lot of the commensal organisms in the gut, and then C. diff has a little bit of time to sort of overwhelm the microbiome and become an infectious process. And so usually you'll see that relatively quickly. And again, it will be more of an acute diarrhea in most cases. On occasion, I've been surprised with patients who've had a few months of symptoms, and we check a C. diff test and it is positive, and the patient gets better with treatment. And so you can be fooled that it can be a little bit more subacute, but for 2 years, as long as it's been sort of consistent, it wouldn't be as common of a cause.
And another question regarding the diarrhea, if we think of chronic diarrhea, sometimes we tend to think between, is it secretory, is it inflammatory? In what kind of bucket would you put this diarrhea at the moment?
Yeah, that's a great question. So the most helpful differentiating factor, and I like the sort of 2 buckets of secretory and like osmotic diarrhea. And the way that we think about it today is really like, is this a problem with electrolyte transport? Either too many electrolytes like chloride being excreted into the lumen of the GI tract, bringing water with it, or a failure to absorb electrolytes due to issues with electrolyte transporters? Or is it an issue where there's some sort of exogenous osmotic agent like Miralax, for instance, or any other type of sort of, sometimes magnesium could do it, things like that draw water in. And so in this case, what we can tell with nocturnal symptoms is usually, as long as they're occurring sort of later in the night, that they're probably not associated with food intake. And so this would be more of like a secretory diarrhea or some sort of issue with electrolyte transport or of inflammation of some sort, rather than something like a lactose intolerance or some other food-related or osmotically active agent. And so it's really helpful to get a history of like how these symptoms change with meals. And then also, is it occurring during fasting? And that's when we start to think about more of electrolyte transport issues.
Thank you so much for all these amazing pearls. Then Dr. Richardson, could you please share the second aliquot with us?
Yes, and then really quickly, I think someone mentioned this in the chat. Important to know how the C. diff was diagnosed, and it's a little bit of a question mark C. diff diagnosis in her case, because reviewing this case, I looked back in the chart, and it was really GDH, which is similar to our PCR in our system, positive, but toxin negative. So unclear if she really had C. diff. Moving on to the next section. So in terms of her past medical history, she has sickle cell trait. She had a right nephrectomy for history of RCC, but not currently on any therapy and just getting surveillance. And this is more of a GI past medical history, but she did have a prior colonoscopy that we had available to us, which was done prior to the onset of her symptoms. And it showed sigmoid diverticula and narrowing of the lumen in the sigmoid, and that's all we were given. In terms of medications, she was on an SSRI, but not taking any NSAIDs. She has no family history of any GI malignancy or inflammatory bowel disease. In terms of social, she's non-smoker, no alcohol use, and no recent travel.
Okay, so Dr. Flanagan, is there anything that helps you to narrow down your differential right now?
Yeah, so it's helpful to, especially with the medication history, to know that really it's just an SSRI. So some SSRIs can cause GI upset, most commonly diarrhea, sometimes nausea. So I would keep it on the list as a potential contributor, although up to 6 bowel movements per day is quite a lot. And an SSRI usually alone will not cause that degree of symptoms. Similarly, SSRIs usually, if they cause GI symptoms, it's for the beginning few weeks, and then the symptoms become less severe. And so SSRIs are always something to think of if they were recently started as a cause of GI symptoms, but in this case, probably less of a contributor. And then it's also helpful to know that she's had a prior colonoscopy. And so this was presumably in the past couple of years in the setting of the diverticulitis. And so we can say with some degree of certainty that she didn't probably have ulcerative colitis seen at that time. And so while it's still not it's still not a likely thing on the differential, it becomes even less likely because we didn't see it previously. We also know that she doesn't have any family history of IBD, which is not necessary, but always raises more suspicion. So I think overall this information is helpful, but I'd still want to get a sense of whether she has any other exposures like over-the-counter medicines or herbal supplements, things like that. And then also get a sense for ideally at some point we'll get to thinking about doing another colonoscopy, because if this is something like microscopic colitis, then we really need biopsies to diagnose that. There's not really a lab test that we can do to diagnose it. And so I sort of think about that as being a very important diagnostic step, and I know we'll get there later.
What I wanted to ask is there any exogenous factor that can trigger something like a microscopic colitis?
Yeah, so certain medications can certainly do it. The ones we commonly hear about are NSAIDs. PPIs can also be a trigger. SSRIs have had some possible association with microscopic colitis, though not quite as strong as NSAIDs and PPIs. There are some other medications, but those are the biggest ones that we come across. And so usually being able to stop those if patients on them can be very helpful for long-term management.
Amazing. And another question that came up is, since this patient has a sickle cell trait, and sometimes we tend to think of complications like any kind of vaso-occlusive crisis that can happen or bleeding that can be associated with it, would you see her at risk for anything as a complication from her sickle cell trait with these symptoms right here?
Generally not with sickle cell trait alone. If someone has sickle cell disease, they certainly can be at risk for ischemia of many types. And in our case, we'd be most concerned about whether this could represent ischemic colitis. Again, with sickle trait, that's less, we don't really see that. But certainly if someone was having vaso-occlusive crises, we would start to think about whether the patient could be at risk for something like ischemic colitis, but that usually comes with very acute onset episodes, hematochezia as being a predominant sort of feature, very significant abdominal pain usually, not really fitting with this sort of presentation, but definitely something to think about if a patient has sickle cell disease.
Thank you so much for this amazing teaching. And
Yeah.
Dr. Richardson, would you like to share the next aliquot with us?
Yes. So her temperature was 36.7, heart rate of 82, blood pressure 115/79, respiratory rate was 18, and she was satting 99% on room air. In terms of exam, general, she was well appearing and no acute distress. Very mildly dry mucous membranes, regular rate and rhythm, no murmurs, and her lungs were clear bilaterally. In terms of her GI exam, she was soft, mildly distended, not and mild tender palpation in the sort of periumbilical area, as she reported. And then in terms of skin, there were no nodules, she was non-jaundiced, there were no obvious rashes that we saw.
So, Dr. Flanagan, does this exam help you to narrow down your differential right now?
It does, to be honest, it doesn't help a lot. And that's something we often find, unfortunately, in gastroenterology, that the abdominal exam is very important, but we can only gather so much information from it. We are seeing that she has this mild distension and tenderness. And so clearly there's something that's probably inflammatory or at least causing pain in some way that's going on. But but we don't get a ton of information from our exam here. But that's not unusual, I would say, in gastroenterology. We often are relying on things like labs, imaging, and then our scopes to really get more information. And it's not to downplay physical exam. I think it is really important, but I think it's being aware that we have limitations in terms of what we can really glean from it.
So since the exam was not that helpful at all, one question would be about the hematochezia that she had. Just the question, when we talk about lower GI bleed, would you think that this hematochezia is due to this diverticulitis that she has, or generally, what do you think of GI bleed? So as an approach.
Yeah. So it's an interesting and probably important detail here, because small volume hematochezia that's intermittent, the most common cause is something like hemorrhoids, which could be flared in the setting of diarrhea. And so that's probably the most common, but the least concerning cause of hematochezia, along with diarrhea. And so we have to think about sort of what else could be causing hematochezia. And so I would say that something like microscopic colitis, which I brought up before, is not a common cause of hematochezia. And so if that were to be the diagnosis, there would have to be two things going on. The patient would have to have some hemorrhoids or other cause of hematochezia in addition to microscopic colitis. Now, if the hematochezia is related to the diarrhea, we would be arguing that there's more of an inflammatory cause. And so things that can be inflammatory causing hematochezia and diarrhea, to go back to segmental colitis associated with diverticulitis, that's where we see some inflammation that looks similar to the inflammation in something like ulcerative colitis, but in between the diverticula. And we don't fully understand the pathophysiology behind it, but you get this inflammatory response, usually in the sigmoid colon, because that's where the diverticula are. And that can certainly lead to some hematochezia, to some pain, and to some altered bowel movements and diarrhea. And so I would continue to think about that as a potential unifying diagnosis. The way we would know that would be to go in and get biopsies, first look at the area and then get biopsies if there's inflammation. In terms of bleeding itself, I'm interested to know what the patient's hemoglobin is, because that'll help us understand how bad the bleeding is. If the hemoglobin is normal or slightly below normal, I'm not so worried about it. Whereas if the patient has developed anemia or significant anemia, it will make doing a colonoscopy, not just for diagnosing the underlying process, but potentially treating the source of hematochezia much more important. And so that's sort of how we're able to tell how quickly the blood loss is occurring, and how serious it is in terms of an actual problem versus just a sort of symptom of an underlying disease process. In this case, it seems so far it's more of a symptom of an underlying process than a driver, but we need a little bit more information in terms of hemoglobin.
Thank you so much. Then I would ask Dr. Richardson, would you like to share the next aliquot with us?
Yes. So in terms of labs, a white count of 11, hemoglobin of 9.2 with an MCV of 75. Because of that, we also have iron studies, but only have ferritin of 250 and an iron of 76. We have a CRP of 32 and a calprotectin of 856. And we also have some stool microbiology. So we have a C. diff toxin negative, GDH positive again, stool culture, which at our institution looks at Salmonella, Campylobacter, and Shigella, which is negative, rotavirus negative, adenovirus negative, and then a TSH of 2.3. I'll pause here because there's more information, but.
So that's that's a great set of labs. The things that are helpful, good, since we're just talking about hematochezia, we have a ferritin and an iron here. And and we also have the hemoglobin and MCV. So after hearing the hemoglobin and MCV, the first thing I thought is the iron deficiency anemia, because the MCV is low, below 80, and the hemoglobin is low. But the ferritin being 250 is not entirely consistent with that, because usually we'll expect a ferritin somewhere below 50, sometimes as low as 15. The sort of thing that could be going on here is that ferritin, as we know, is an acute phase reactant. And so you can see ferritins in the 1 to 200s if there's acute inflammation going on, even if there's underlying iron deficiency. And so in this case, there's sort of what I would say probably two things going on. There probably is some degree of iron deficiency, and there's also likely acute inflammation because we have a calprotectin of 856, which is elevated, and a CRP of 32, which is elevated. Both, I would say, are relatively moderately elevated. Patients with severe ulcerative colitis will generally have CRPs 50 to 100 or more, and calprotectin's greater than 1,000. It certainly doesn't rule out ulcerative colitis, but it's sort of in the more moderate inflammation category. Unsurprisingly, the stool culture is negative. In the C. diff, the results are always sort of tantalizing in that they never seem to be straightforward. And so this would be consistent with potentially a prior infection and colonization. Again, her whole clinical picture is almost more important than the C. diff testing to say that this probably is not an acute C. diff presentation. And then finally, the TSH is helpful because hyperthyroidism can sometimes present with diarrhea. And so thinking about other causes of sort of more systemic diseases that could be at play is also really important.
Amazing. And just as a question right now, what would you make now in terms of management in order to find out what could be the culprit for this case here?
Yeah, it's a great question. So I definitely am more concerned that there's some sort of active inflammation going on with the elevated calprotectin and with the hematochezia and with the anemia. So this has been going on for a while, and the patient's likely been losing some blood slowly. And so it would be really important to get colonoscopy and directly visualize the mucosa. Imaging is not wrong, but the question is, what we'll be looking for? And so most of these patients will have had a CAT scan to see, if there's any sort of malignancy or other process that's going on. But generally, unless it's something like a neuroendocrine tumor or something like that, generally a colon cancer will have a slightly different presentation with less diarrhea. Although, it's never something we would rule out entirely. And again, the colonoscopy would be able to help us there. And so I tend to rely mostly on getting a colonoscopy and direct visualization and getting biopsies because I think imaging can only be so helpful. The other thing to think about with imaging is if you're thinking about an ischemic colitis or some sort of vascular process, you would think about getting something like a CTA to look at the vasculature. In this case, I'm not entirely concerned about that. And so I wouldn't jump to getting that at this point. I would more focus on getting more diagnostic information through a colonoscopy.
Amazing. And another question is, what do we make of the stricture that has been seen on prior colonoscopy? So the question would be, is it something like a scarring from prior episode of diverticulitis? Could this be any signal for something like Crohn's disease or any bowel damage during surgery? So what would you make of this?
Yeah, it's hard to know exactly what to make of it. We do see oftentimes with diverticulitis that's been recurrent and or severe that patients can get sort of luminal narrowing. And it can even be so bad so that, it's almost impossible to complete a colonoscopy and get through that area. And so the diverticulitis alone could be the cause of that. but it could also be sort of inflammation, either from sort of smoldering diverticulitis or something like the segmental colitis associated with diverticulitis, the SCAD sort of diagnosis, would have inflammation that can also cause luminal narrowing. And then the thing we worry about most is whether a colon cancer could be causing the luminal narrowing. Although, like I said, in this case, it seems overall less likely as an underlying sort of unifying diagnosis here.
Thank you so much. Then, Dr. Richardson, would you like to share the next aliquot with us?
Yes. So, of course, we got imaging and endoscopy. So we got a CT abdomen pelvis with IV contrast, which showed circumferential colonic wall thickening involving the distal descending and sigmoid colon with intramural sinus tract and few foci of air. And then given all of the things that Ryan talked about, ultimately she got a flexible sigmoidoscopy, which we had a normal digital rectal exam, no hemorrhoids, rectum with normal appearing mucosa. And then in the sigmoid, we saw ulcerations, fibril mucosa, diverticula, and luminal narrowing that was seen before. And I also have pictures of the endoscopy, which I can share my screen now. Oh no. Let's see. Oh, sorry, too many tabs open. You can keep going and I'll figure out how to do it.
Okay, Dr. Flanagan. So seeing now this information, does it help you to narrow down your differential?
Yeah, so the CAT scan is quite concerning, I would say. When we hear about the wall thickening, that's fine. But when we hear about the intramural sinus tracts and few foci of air, that's not something we see on a lot of CAT scans. And so that makes me more concerned that there's sort of active inflammation. There's some sort of infectious process, like the bacteria are probably causing that are in there are probably causing some degree of inflammation. And the foci of air, it's always important to know in someone with diverticulitis, if that air is just the diverticula themselves, they're these little pockets, and certainly they can fill with air, or is it actually air that's not in a diverticula, but it's in the wall itself, something called pneumatosis, because that is very concerning that the patient could have perforation and require surgery relatively quickly. And so definitely something that would give me pause before doing a FlexSig, but in this case, we really need a diagnosis and we don't have another way of doing it. And so I actually think that doing a FlexSig is the appropriate thing, being very gentle on air insufflation and being careful to not cause any trauma to the wall of the sigmoid colon. And so then the FlexSig itself showing ulcerations, the friable mucosa, the diverticula, and the luminal narrowing certainly could be SCAD again. It's important to know the reason the pictures will be helpful is knowing if the ulcerations are occurring in between diverticula can be sort of pathognomonic versus something like a colonic Crohn's disease that could be sort of ulcers anywhere versus some other etiology. So I see the pictures here now. And it looks like they're sort of like these sort of like punched out ulcered areas. And you can definitely see the narrowing in the bottom picture. And I don't see a lot of diverticula here. And so it's sort of, it may not totally fit with something like SCAD, although I wouldn't totally rule it out just based on the pictures. But I think when getting biopsies of an ulcer, I think this is a key point, that if we think it's some sort of chronic infectious process, like a virus, so something like CMV can look like this, or something, other viruses, you want to make sure that you get samples from the edge of the ulcer as well as a sample from the middle of the ulcer, because depending on the organism, there may be a preference for one area or the other. And so you want to get multiple samples, both from the normal looking tissue, the edge of the ulcers, and the middle of the ulcers, because that is going to be extremely important in actually being able to find organisms like viruses or bacteria as a cause of these ulcerations.
Thank you so much. And you, as you mentioned, scared. So seeing these symptoms here, sometimes as a differential, we might also think of something like inflammatory bowel disease. So what helps you to differentiate it from inflammatory bowel disease, and how would you diagnose it?
That's a great question. And even today, there's not one test that can 100% diagnose inflammatory bowel disease. And so it is a combination of sort of all of the information that we have. So in this case, ulcerative colitis, we would see normally inflammation in the rectum working its way more up to the sigmoid. We don't see that in this picture. So what we see is discrete ulcers. And so Crohn's disease occurring just in the colon would be a possibility. And that can cause sort of some hematochezia. So it can certainly cause some watery bowel movements and cramping abdominal pain. It would cause an elevated calprotectin if it's causing colonic inflammation. And so what we want to see is we want to see signs of chronicity on biopsy. Granulomas are often the thing we think of with Crohn's disease. Those are only present in about 40% of biopsies of Crohn's disease. And so if there aren't granulomas, it doesn't really rule it out. But if there were granulomas, that would basically be a definitive sort of diagnosis. And so if we saw evidence of sort of those chronic findings, like crypt distortion and things like that, that we see in more of a chronic inflammatory process like Crohn's disease, then that certainly could be what's going on. Crohn's disease also can lead to stenosis. It's much more common to do that in the small intestine than the large intestine. And this area for Crohn's is actually a little bit unusual in that most people do not have isolated Crohn's disease in the sigmoid colon. It would be much more common to have disease affecting the ileocecal valve, which is the most common area for it. But as we know with Crohn's disease, it can affect any part of the GI tract. And so we've seen isolated cases of Crohn's in the stomach, for instance. We've seen it in the esophagus, so we could certainly see it in the sigmoid colon. And so nothing up to now really rules out Crohn's disease, while a few things sort of make it a little bit less likely. Really, we need the pathology to say that it's not an infectious process like CMV or another virus, and that there's signs of chronicity that are consistent with that, to sort of lean in that direction.
Thank you so much. Then I would ask Dr. Richardson, would you like to share the next aliquot with us?
Yes, so we have our path back. We know that our rectal biopsies, as correlated with endoscopic findings, have normal mucosa. And then the sigmoid biopsies we obtained showed mild chronic active colitis, neutrophilic cryptitis, crypt architectural distortion, and Paneth-cell metaplasia.
Great. So that's very helpful. Oftentimes I was very concerned that it was going to just be chronic active colitis, because oftentimes when we get biopsies in patients with a little bit of inflammation, we see colitis without any other features of what might be the underlying cause. And so things like neutrophilic cryptitis, crypt distortion, which I mentioned, and Paneth-cell metaplasia, those are all more chronic features of inflammatory bowel disease. And so we see those as things have sort of gone on for a long time. And so if this patient had come in a few weeks after symptoms started, we didn't see these things. Sometimes we need sort of more time to see how it develops. But this is actually much more concerning for sort of inflammatory bowel disease, and most likely Crohn's with the presentation that we see in the colon. So hopefully that's correct. I will say though that some of the features of SCAD can mimic IBD, and so I would say that that's not totally ruled out. But from the pictures that we see here, it seems like it's more discrete ulcers, and these findings are much more classic for Crohn's disease.
So I'll add something to help with this. I think the diagnosis is sort of to be determined. So 2 pieces of information I'll add. One, the patient was started on a 5-ASA mesalamine and her symptoms got a lot better. But 2, we do not have a full colonoscopy yet. So how does that change how you think about the case?
Yeah, that's a great point. So ideally, in most of these cases, we want to get a full colonoscopy, because if there was ongoing inflammation at the IC valve, it would be much more conceivable that this would be Crohn's disease. If we go and the rest of the colonoscopy is sort of normal, then I would still consider SCAD being a potential cause. And it's often hard to separate these 2 things because they both can respond to the same treatments. And so 5-ASA may treat both of these things. And so again, it's a little bit hard to totally differentiate with the FlexSig alone, not knowing if the other parts of the GI tract are involved. And so that's sort of, I guess that I would say that that's sort of what we know so far. But with 5-ASA working, I would continue that long term and sort of follow a lot of these markers. So we have a hemoglobin that's low. We want to make sure that that resolves and improves. We have the calprotectin, so we can continue to follow that with treatment and see if that improves. And then we sort of, once ideally the inflammation comes down a little bit with treatment, we'll be able to do a full colonoscopy with additional biopsies and really see, is this an isolated process, which SCAD would be, versus is this something involving a more significant portion of the colon that we just haven't fully characterized yet. And then I would think it could be more likely Crohn's. And I think the difficult thing in medicine is if we don't fully have a diagnosis, it's sometimes very unsatisfying. But in this case, if we know that it's an inflammatory process and that it's getting better with anti-inflammatory treatment with a 5-ASA, and if the patient gets better, then we can still have a really successful outcome, even if we don't 100% know ultimately what's sort of the driver behind it, or what's the underlying pathophysiology.
Amazing pearls. And Dr. Richardson, what do you think about this case so far?
I think I really wanted it to be SCAD, but I think I agree exactly with Ryan about it's sort of incomplete right now, and really the full colonoscopy is going to be the differentiator. I would say when I looked into SCAD, it's interesting. I think it's not much is known about it because a lot of the cases are more indolent than UC or Crohn's, meaning they sort of fly under the radar. And so this one, if it is truly SCAD, is sort of one of the more impressive or significant presentations, I think, that, based on what I've seen in the literature. But yeah, I think it was just a sort of interesting teaching points to me when I was going through the diagnostic process. The other thing too, for this patient is that because her presentation was more diarrhea than maybe say fevers, abdominal pain, cramping, if it's more with, maybe Crohn's and SCAD, but, when patients have episodes of diverticulitis, their risk of getting recurrent episodes increases every single time. So it is possible that she's had just recurrent diverticulitis too. But given the chronicity on the path and some of the other things we discussed today, I think it's also less likely. And I have to say also, her hemoglobin is better, her CRP is lower, and her calprotect is lower too. So she is responding to treatment.
Thank you so much. And just to clarify for the listeners there, like for me, I've also heard for the first time about SCAD. Would you like to share some teaching points about SCAD generally? And as you said, that this is an IBD mimicker. So is there something specifically that helps you to differentiate it?
Yeah, it's a great question. There's a few sort of hints. I would say nothing 100% definitive, but there's a couple hints. So generally, segmental colitis associated with diverticulitis is exactly what it sounds like. It's segmental. So if a patient has Crohn's, they may have lesions in multiple different areas. They may have systemic signs of Crohn's, like arthralgias, ulcers in the mouth. If we had done, for instance, small bowel imaging, like dedicated small bowel imaging in this case, like enterography, either CT enterography or MR enterography, we may see something showing up in the small intestine. So Crohn's generally will affect multiple different areas, although not always. But segmental colitis associated with diverticulitis will just be in the area of the diverticulitis. So for instance, you cannot have sigmoid diverticulitis and then have ulcers in the cecum, the right side of the colon, and call that SCAD. It's really that the inflammation is in between the diverticula, and it's just in that one area. And then when you biopsy it, the problem is that oftentimes on histology, it does look like inflammatory bowel disease, likely because there's some probable shared pathophysiology, whether it's altered microbiome or altered sort of inflammatory response to bacteria that may be living in the diverticula. It's sort of unclear, but the biopsies by themselves won't always distinguish. The most helpful thing is what it looks like in terms of what segment, whether it's in between the diverticula and only in a certain section, or whether it's something much more widespread, part of a bigger disease, which would be more like Crohn's. And so can be very difficult to tell these things apart. And that's where we really have to rely on colonoscopy. And in this case, it wouldn't be unreasonable at some point to do an endoscopy to see if there's any Crohn's in the upper GI tract, or to do a small bowel sort of interrogation with enterography to see if there's any inflammation in the small intestine, because those are also things that could point you more towards Crohn's. Again, if those things are negative, we're still left at square one. And that's why I think what makes this fun is that there's lots of tests we can do, but what makes it sometimes frustrating is when we don't get the answers from those tests, and it's hard to differentiate between these two entities for sure.
And in terms of treatment, do people that have SCAD also require aggressive immunosuppressant therapy?
Yeah, so not always. So some SCAD is very, very mild, doesn't require any treatment at all, and can just be watched, and sometimes it will resolve. Sometimes patients will be started on 5-ASA, such as mesalamine, sort of a mild anti-inflammatory medication that we use in IBD. And then very rarely, I have not seen something like an anti-TNF, like infliximab. I haven't really seen that being needed to be used for SCAD specifically. However, in Crohn's, we very, very commonly use those medications because something like mesalamine is generally not that effective for Crohn's compared to ulcerative colitis, where we more commonly use it for mild ulcerative colitis, and Crohn's is not that helpful. And so again, where it helped in this case, does that make it more like, more likely to be SCAD versus Crohn's? Hard to say, but generally, you won't see much benefit from mesalamine, although in this case, because it's in the colon, you certainly could if it's just isolated Crohn's colitis.
Thank you so much for this phenomenal teaching. Before I will ask you about your highlight teaching points from the session, I would like to ask Dr. Richardson, do you have any final remaining words for this case so far in this discussion?
No, I don't think so. I think Ryan said everything I would say. I'd say the only other thing besides 5-ASAs that are often used is there's thought to be a role for antibiotics potentially, which is also sort of similar to some of IBD. But that's all that's sort of been proposed in the literature. And yeah, I'm just happy she's doing better, and I'm excited to see what her colonoscopy shows.
Thank you so much. And I see we have one last question that is about how do we explain the intermittent nature? Or was it that she had these other processes and then was unfortunate enough to develop SCAD?
I think whether it would be SCAD or Crohn's, you could have some sort of like intermittent worsening. The fact that it's been 2 years could fit with either again. So I think it doesn't help us one way or the other between those two diagnoses. SCAD can be sort of this subacute to chronic inflammatory process, just like Crohn's.
Thank you so much. And I would ask you, what are your 3 highlight teaching points from this session?
Yeah, so I think whenever we hear about someone coming in with diarrhea, there's a really important distinguishing between irritable bowel syndrome and everything else. And because we want to be thinking about irritable bowel syndrome because it's so common, and because we can do a lot of testing when we shouldn't be. But the things that steer you away from irritable bowel syndrome are things like hematochezia, any blood in the stool, any significant amount of bowel movements, like in this case, 6 or more. Nocturnal symptoms are very uncommon with irritable bowel syndrome. And so think about irritable bowel syndrome first because it's so common, but pay attention to the symptoms that may be pointing you towards something else, like an inflammatory process. Another important teaching point is always think about microscopic colitis. It's something that we see in GI relatively frequently, but in general medicine, it's not all that common. And so any patient who's sort of on the older side, 50s, 60s, 70s, who is coming in with chronic diarrhea without another clear cause, always think about microscopic colitis. And that is a diagnosis that requires a colonoscopy with random colon biopsies. We usually do of the right and left colon to see if there's evidence of microscopic colitis. It's called microscopic because you can't see it when you do the scope. You can only see it when you look at the histology. And then lastly, differentiating between SCAD and IBD can be very, very hard and sometimes academic. But segmental colitis associated with diverticulitis is generally in one area associated with the diverticulitis or diverticula. So you'll see the diverticula and you'll see the inflammation in between the diverticula. And you won't see inflammation elsewhere in systemic symptoms. If you see those things, think more inflammatory bowel disease as an underlying cause.
Thank you so much for this phenomenal teaching. I learned so much, and I think the listeners there will too. So then again, thank you so much for being here, and we hope to see you soon again. And then I would say goodbye to everyone and hope to see you soon again. Bye.
Bye. Thanks for having us.
Thanks.